Our first presenter today is Dr. Chelsea Walton, a clinical psychologist at the Wellness Center. Dr. Walton incorporates elements of cognitive behavioral therapy and mindfulness-based interventions in her work with clients with the aim of helping them move beyond their challenges, achieve their goals, and find joy in the present. And today she will be presenting on perinatal mental health awareness. Dr. Chelsea?
Good morning. It is my honor to be here today on the final day of the healthcare conference to present on a topic that is of personal and professional interest to myself, and that's perinatal mental health. And so maybe this is a topic that you have heard kind of gain more conversation in recent times. If not, that's okay. The purpose of this presentation is to share some information on this topic, and hopefully leaving here you will have a better understanding of what this is and what we can do to support the population. Oh, pointing the wrong way. Okay. All right. And so perinatal mental health, what is it? That's something that we'll be defining in this presentation, as well as some of the difficulties that may present in pregnant women or women in the postpartum period. Dads also included, but we'll be talking a bit more about kind of mood and anxiety disorders, what that looks like, why it's important for us to be able to identify and address these mental health concerns, as well as what are some of the benefits of addressing these difficulties and supporting this population, and what are some of the things that are associated with unmanaged mental illness in parents? Keep forgetting that, sorry. Okay. All right, so what is perinatal mental health? So that just refers to a woman's state of mental and emotional well-being during pregnancy and the postpartum period. And this definition can also include dads as well, as they also, as you'll learn throughout this presentation, can struggle with mental illness as it relates to the transition to parenthood. And perinatal refers to the period from kind of conception through the couple of years following childbirth. And so there's some kind of debate about how long the postpartum period is, but when we're talking about perinatal mental health, because depressive symptoms can persist beyond kind of a year post-childbirth, the period is kind of extended. So that we can continue to kind of track and monitor symptom progression during that time and ensure that parents receive kind of the support that they need in those early years. Okay, and so although this isn't a topic that is maybe widely discussed, maybe we've noticed that, over recent years, there's been more discussion about mental health issues. People are talking about it more openly. There's a lot more advocacy, research, and focus on kind of treatment, reducing stigma. This is an area that is kind of is not well researched, or there's not a significant kind of focus on in general, but it's important to kind of include this within the broader conversation about mental health, because either through our experiences as a healthcare provider, we're likely working with someone who has the potential to be impacted by perinatal mental illness, or in our personal lives, if we have ever given birth, if we know someone that's given birth, we're born, we're here, right? It's relevant, both personally, definitely, and professionally, it's very likely that it is as well. Okay, and so it was first kind of referenced by Hippocrates way back when, who, I mean, just the father of medicine, noticing that, there were changes in the mood of women, particularly in the postpartum period, and then maybe we didn't really hear too much about it again for the next, millennium and a half, but a French psychiatrist, Louis Marseille, published the first paper on perinatal mental illness or postpartum mental illness. And so kind of after that point, a lot more discussion, awareness, research, and focus on treatment has begun to evolve, especially in the past few decades. And then through the 1900s as well, the Marseille Society was founded, which their goal was really to focus on those things that I previously mentioned: research, treatment, and providing support for those in the perinatal period. Okay, and so something that has kind of helped to solidify perinatal mental illness as, a condition that is worth researching, understanding, talking about, and focusing on treatment is its inclusion in the DSM-4. So that's the Diagnostic and Statistical Manual of Mental Disorders, and that is a diagnostic tool that's used by mental health professionals in diagnosing mental health concerns or mental disorders, psychiatric illness. And so with that being added to the DSM, that's really helped to kind of just highlight that this is an area that is worth exploring further. And with that, we can develop ways of better kind of conceptualizing difficulties that may occur in this population in terms of mental health, as well as provide treatment. And so kind of in today's age and in recent years, there's been a lot more discussion, especially on social media, about some of the challenges that parents face, mothers in particular, during pregnancy, their experiences, the transition to motherhood, so matrescence, as well as some of the mental health challenges that fathers face. Those are things that are kind of entering kind of the consciousness a bit more over recent years, and now there are a lot of providers that are certified in perinatal mental health. There's more resources available. There are virtual support groups that are available online, and this presentation really, the aim of that is to help kind of further that discussion. And so when we're talking about perinatal mental illness, there's a term that kind of just helps to kind of encapsulate the different psychiatric disorders that we might see in this population. So that's PMADs, perinatal mood and anxiety disorders, and that encompasses depression, anxiety, bipolar disorder, psychosis, as well as postpartum post-traumatic stress. And we'll talk a bit more in depth about what these disorders can look like and how these present in a perinatal population. Okay, and so why is this even kind of worth talking about? How prevalent of an issue is this? So before COVID, the CDC estimated that 1 out of 8 women in the US experienced postpartum depression. And so that's a significant number of women that are experiencing this. And in the early stages of COVID, that number increased to 1 out of 3 women being screened positive for postpartum depression. And that was attributed to a lot of the stresses that we faced throughout COVID, such as social distancing, threats to our health, the health of our loved ones, our families, restrictions on travel. It really disrupted the social support aspect that a lot of new mothers could expect to get or would kind of hope or anticipate to get during that time, right? So having family be able to travel and come visit mom and baby, maybe even leading up to childbirth, right? With restrictions in the hospitals and social distancing, then maybe partners and other social supports weren't able to attend a prenatal appointment. There's the worry about who's gonna be able to be there during delivery as well, hoping that person didn't have COVID at that time. And so there was a lot of stress during that period, and it did really make this population quite vulnerable to experiencing perinatal depression, postpartum depression specifically. And throughout this presentation, I'll kind of mostly refer to the mom and maternal mental health, just because moms are most directly impacted by pregnancy and childbirth and physiological changes postpartum. But I think that it's also important to recognize that fathers can also struggle with their mental health as it relates to their transition to parenthood, to fatherhood. So 1 out of 10 men in the US were estimated to struggle with paternal depression, and the strongest predictor of that was depression in the mother, even beyond the father's previous history of depression or any kind of psychiatric illness. And so something else to kind of consider as well is because a lot of this data isn't coming out of our community necessarily, it's coming out of the US and other areas, but that this is actually a global experience. Rates are pretty similar across the globe, even though they're a bit higher in the Western world. But this is something that does not discriminate. It can impact anyone who is part of a childbearing family, and there are obviously risk factors that will increase the likelihood that someone will develop a psychiatric disorder in this perinatal period, but overall just being kind of mindful that this is within our community as well. Okay, and so there are some concerns, even with seeing that there is a significant number of mothers who have been estimated to have perinatal depression, that that there is underreporting of these symptoms, and a lot of that kind of comes down to stigma. So it can be really difficult for parents, new parents, to kind of move beyond the expectations that they may have of themselves, that society kind of imposes, the messaging that pregnancy is supposed to be a joyous time, you should feel nothing but bliss, you have that pregnancy glow, you should, as soon as you meet your baby, you're gonna fall deeply in love, and everything is gonna be amazing, you'll be great, you'll just experience unadulterated bliss and joy. And so those expectations can prevent mothers from kind of opening up about things that they're experiencing that are distressing, that are impacting how they're functioning, that their mental health might be deteriorating. And then the other side of that, in terms of why rates might be variable, or maybe we're not kind of capturing everyone who might be impacted by postpartum depression, is that there's concerns about it being under-identified. And so per the American Academy of Pediatrics, a survey done in 2013, and it was replicated again in 2019, indicated that less than half of pediatricians screened for postpartum depression. And you might be thinking, well, their role is not necessarily to kind of take care of the mom. Their role is to kind of focus in on the baby. But in the postpartum period, usually one of the healthcare providers that has the most frequent contact with mom is a pediatrician. And so this is a really good opportunity for these symptoms of postpartum depression to be identified and for some assessment to be incorporated in those appointments, right? And so kind of keep forgetting that. All right. And so something else to kind of consider as well is that the prevalence of perinatal depression in women with low income pretty much doubles. And so that's a risk factor, and that's a statistic that is quite alarming and significant, and something to kind of keep in mind if you are working with this population, that there is a likelihood that this is, that they're at greater risk. Okay. So kind of moving along into what is depression, anxiety, what this looks like, and what this looks like in this population. And so it can be helpful to have a bit of an understanding of kind of what are some of the signs and symptoms of depression. So major depressive disorder is characterized by having low mood, a depressed mood for most of the day, more often than not. And there are a lot of physiological symptoms that are associated with depression, such as, fatigue, feeling lethargic, disturbances in sleep, so maybe oversleeping or having difficulty with sleeping, insomnia, as well as appetite disturbance, maybe overeating or not having an appetite that leads to unintentional weight loss or gain. There are also the emotional aspects as well, such as feelings of, excessive guilt, feelings of hopelessness, worthlessness, thinking that things will kind of never change, never improve, that they'll be stuck in their circumstances, as well as some, their thoughts about death or dying or harming oneself. Those can be a picture of depression. And so it doesn't always show up in maybe the ways that we stereotypically think. A lot of individuals are able to kind of mask their depression, right? Kind of everything looks good on paper, but we don't know what this person is kind of dealing with internally. And so that's where kind of being open to kind of having these conversations is helpful in kind of identifying the well-being of a new mom, or kind of anyone in general, because we all have mental health, right? But for the purposes of this presentation, moms and new dads. And so how depression may show up in this population is that it might look like, a mom that's very overwhelmed, is very frazzled, very stressed, kind of zoned out, touched out, may struggle with caring for themselves, struggle with caring for their families, may not respond to things that they usually enjoy or find pleasure in, whether that's activities or connection with others. They might be a bit more isolated or kind of withdrawn. There can be an increased reporting of those somatic symptoms that we discussed in the previous slide, like some of those GI problems, aches, pains, that might be a part of the presentation. But sentiments such as kind of like, I don't feel like myself, this isn't like me, this is not really what I thought motherhood would be like or fatherhood would be like. I don't really feel that connection to baby. Those are all signs that a new mom might be struggling with postpartum depression. And so those are things to kind of look out for in working with this population. Okay, and then some of the things that were described as being part of depression, like sleep disturbance, appetite disturbance, it can be a bit difficult to kind of differentiate, why is this occurring? How is this different than what, moms, pregnant moms, new moms experience, right? Because, we are aware that there are a lot of physical changes that occur that can lead to pregnant moms experiencing some of these things. And so the ways that they differ is that, with pregnant moms, when there's sleep disturbance, usually due to kind of physical discomfort. So, difficulty kind of with getting comfortable, with like their sleep not being disturbed because of, heartburn, needing to frequently get up to use the bathroom throughout the night. They may also, appear to be quite emotionally reactive and tearful, may cry at things like commercials, right? But mood is generally a bit more positive and labile. So there are fluctuations in the mood. It's not kind of a low, depressed, gloomy, or irritable kind of presentation that you'll be seeing. Appetite will tend to increase across the course of the pregnancy as there are increased demands on mom for energy. Mom is, does have some joy and anticipation, even if that is mixed in with worry. And suicidal ideation isn't a part of the typical pregnancy, right? And so in terms of depression, it looks like a lot more kind of like what we described in the previous slide, right? So there might be kind of more of a gloomy mood, gloomy kind of presentation, or maybe it shows up as being irritable or angry, or I don't know if you've heard the term kind of mom rage, right? Those are kind of more along the lines of what can be experienced emotionally. There may also be kind of low self-esteem or guilt present, difficulty with sleep, but not for the regular reasons such as, the heartburn or needing to use the bathroom throughout the night. Mom may be fatigued, but, even with kind of rest, the energy level doesn't really quite restore. So, that might kind of sound like, yes, I'm getting a lot of sleep, but yeah, I'm not really feeling like it's restorative. I still don't really feel rested. And a difficulty with kind of experiencing pleasure in response to engagement with activities that, they usually like or enjoy, or connecting with others who are important to them. And appetite tends to be dysregulated, and not for underlying medical reasons such as, extreme nausea or vomiting that can occur during pregnancy. Okay, and so to kind of further tease apart another experience that is typical in the postpartum period, but may look like depression, but isn't. It's not mild depression, it's the baby blues, and that's a period of tearfulness, emotional reactivity, exhaustion following childbirth, and it tends to last between 2 days to 2 weeks. And so after 2 weeks, you wouldn't really expect to kind of see that these signs persist. The baby blues kind of burn out after that period of time, and it's caused by hormone fluctuation at the time of birth and acute sleep deprivation. But generally, mom is happy, mom is content, and responds well to when she has opportunities to rest or engage with, her social connections, family, friends, whoever. And so just something to be mindful of. In the next couple of slides, we'll talk about postpartum PTSD, and so we'll reference birth trauma. And though I won't get into any, specific details or, really get into kind of describing situations that it can occur, it might be something that you just want to be mindful of in terms of taking care of yourself. There it is. And so, as healthcare providers, and just as members of a community and family members, friends, it's really important to recognize that we don't get to say what is traumatic for someone else. And this quote helps to kind of encapsulate that. It says that birth trauma lies in the eyes of the beholder. And so a lot of times mothers who perceived their births as being traumatic, those same experiences or events were perceived as being kind of routine by their providers. And so it's important to be kind of mindful of that with working with this population as well. Right? And birth trauma just really kind of refers to any event that occurs that during the labor or during the birth process that can involve actual or threatened injury or death to either the mother or her infant, or the woman feeling as though she's stripped of her dignity or there's a loss of autonomy. And so approximately 9% of women experience postpartum PTSD symptoms. So that might not mean that they meet full criteria for PTSD, but they're experiencing that post-traumatic stress. And so there is that, that experiencing of symptoms that is, difficult and indicates that, something during that process may have been traumatic for the mother. Women who have experienced previous trauma are at higher risk for developing postpartum PTSD. And so, in terms of kind of prenatal appointments and prenatal care and the process of birth, that some of those things that need to occur can be quite re-traumatizing for someone who may have experienced a previous trauma. And so it's just important to kind of keep that in mind when working with this population. And these are some of the examples of experiences that may be deemed traumatic in this population. And so some of these things, are pretty routine, pretty common. We hear about them occurring quite frequently, but just because we may have been desensitized to some of these things or we think they're common, that doesn't mean that they're not stressful and difficult for mom to process and deal with. And so your thought is like, okay, well, you made it through, you're fine medically, everything is good. Maybe we have the data on, what the risk is, but going through the actual event can be quite stressful, and it may take some time kind of emotionally and mentally to kind of recover from some of these events. And that also includes kind of feeling powerless or feeling, as though they didn't have the support that they needed throughout the process of childbearing, or got the reassurance that they needed during delivery. So some of the things that can contribute to a woman experiencing birth trauma and post-traumatic stress symptoms are not necessarily any kind of medical procedure, but kind of speak more to kind of the communication and the support that is provided throughout the birth process. And so postpartum PTSD symptoms, what can this look like in this in this population? So PTSD includes intrusive re-experiencing of the past traumatic event. So that can either be the childbirth itself, or it can be a previous trauma that is being re-experienced. They've been re-traumatized throughout the process of pregnancy, labor, delivery. And so that might look like having images or thoughts about the trauma that are unwanted, that are distressing. It also can look like having flashbacks or nightmares, feeling as though they're kind of reliving it mentally, or again, having that show up as very vivid, difficult dreams about the event. Avoidance of stimuli associated with the event, so that could include, certain places or people that may remind the parent of what occurred that was traumatic to them. And so this can kind of look like, maybe you have a mom who, had an emergency C-section. Maybe her obstetrician was present for that. This is something that was traumatic for her. This is not how she expected that, her birth would go. The process of recovery has been quite difficult and challenging, and she's experiencing kind of negative thoughts about the event, an increased sense of kind of arousal, just feeling on edge, finding it difficult to kind of relax, anxiety, panic, and kind of feeling like, I can't believe this happened to me, like it's kind of surreal, like don't necessarily feel kind of connected with that experience, or I felt like, when this was going on, I was kind of outside of my body watching it happen, right? And so avoidance can occur because when there's, any kind of reminder about that event, the body is kind of remembering the stress of the situation, and really want to there's a drive to kind of reduce that distress. And so it might look like, needing to have certain follow-up procedures or having follow-up appointments and avoiding that, because it is just too stressful to kind of engage with that doctor, or when engaging with that doctor, that parent, that mom might feel like, she's reliving that whole experience again. Okay, I'm convinced it's just me now. I'm clicking in the right direction. It's personal. Okay. Okay. Oh no. Okay, here we go. Okay, and so kind of moving on to perinatal anxiety, because this is another very prevalent psychiatric illness that can occur in this population, and it really looks like having excessive worry that is difficult to control. There's a lot of physiological symptoms, so that stress response is activated. So we can, when dealing with anxiety, experience, rapid heartbeat, rapid breathing, feeling tense, kind of on edge, difficult to kind of wind down, difficult to kind of relax. May feel as well as though, thoughts are kind of racing, our mind is going blank, it's hard to focus, just because once that stress response is activated, the area that we kind of credit for doing a lot of our thinking kind of goes offline. And so this in a new mom may look like, or even in a mom and dad who are, they're expecting, may look like, oh, I think that, something is wrong with my baby, despite being perfectly healthy. They're following, all of the doctor's recommendations. The scans show that everything is going well with baby, and so kind of despite reassurance and despite evidence that suggests that, baby is fine, the pregnancy is going well, there's nothing to worry about at this time. They have difficulty with kind of controlling those worries, and experience these symptoms as a result of that, right? And so something that's interesting to note is that prenatal anxiety rates are fairly similar in moms and dads, and so dads also can be kind of plagued with this worry and this anxiety, and that might be for different reasons. Yeah, there might be thoughts about, oh my goodness, like, what's going to happen with the baby? Is the baby okay? What's going to happen during childbirth? Is something going to happen? Am I going to lose my, my partner and my child? Or it may be about, am I going to be a good dad? Is my baby going to recognize me? Are they going to love me? They're just going to love mom? Can I provide for my family? So the sources of worry may be a bit different, but the experience is kind of occurring at similar rates. And so kind of moving into postpartum OCD. So prevalence rates for this disorder in perinatal population or postpartum population are a bit more variable due to kind of limited research, but estimates are between kind of 1.7% to 7%. And a part of that is that just the kind of the nature of OCD, so the intrusive thoughts that are distressing, that are alarming, this might not be something that a new parent will readily disclose. And so that's a part of why, this might be something that is difficult to kind of identify and difficult to kind of establish some, I guess, more solid statistical data on, or research on, because a lot of times with the thoughts that can occur as part of OCD and postpartum, there's a concern that, if they share it with someone, they're going to think that, they're an awful parent, that their child may be taken from them. But the reality is that those who are suffering with postpartum OCD are often at really low risk of actually doing anything to harm their baby, right? And so how this may present is, a mother in the postpartum period who has these intrusive, recurring, really distressing thoughts or images about, maybe rolling their baby down the stairs, right? And so that is a thought that is really distressing, just kind of thinking about it. I don't think that any of us really are happy with kind of having that thought of something happening with a baby, right? And so a mom may have these kinds of thoughts, right, that she might do something to harm her baby, and as a way to kind of neutralize the anxiety that comes from having those kinds of thoughts, you may see that there are some compulsive behaviors or avoidance, and so that might look like, mom never carrying baby on the stairs, only, dad and grandma are allowed to, carry baby down the stairs. Or can also look like having to engage in certain rituals before, so maybe counting or, repeating certain things internally in their mind before being able to kind of, have that anxiety settle and, be able to kind of move about, right? And so these thoughts are ego dystonic. So these are unwanted thoughts. These are thoughts that this mother does not want to have, or this father does not want to have, and it causes severe distress. And unfortunately, with OCD, the anxiety tends to kind of cling on to what is really important to that person. So again, the likelihood that there will be kind of action behind these thoughts is really, really low. And instead, this is a mom that kind of needs that support and needs to kind of recognize what is happening through, referral to an appropriate source, or just, having it validated that, the thoughts are really distressing, but it doesn't sound like this is something that, she is wanting to do, but she does need some support to kind of work through it, to be able to have some relief and to be able to function. And so common presentations will include harm coming to baby, either deliberately or by accident, or contamination, worry about, excessive worry about kind of germs, that might result in excessive cleaning, organizing, rearranging, or other rituals. Okay, and so postpartum OCD can really lead to moms being caught in a spiral of what ifs. Perinatal women are at a significantly increased likelihood of developing OCD than the general population. And again, they find these symptoms to be severely distressing, and depression also tends to be a part of the picture. And so, again, just to kind of illustrate that, you might not necessarily be able to kind of gauge how, a new mom is doing just by kind of asking, or, making a statement that is, I guess, kind of presumptive that this is, the best time of her life, everything is going well. There can be a lot kind of going on internally, and this is just a little illustration that I like that helps to, highlight that. Okay, and so in terms of some of the risk factors for PMADs, things that will increase the likelihood that a mother will develop a mood or anxiety disorder during pregnancy or in the postpartum period include having a family history of PMADs, and so having that genetic predisposition to this experience, as well as a personal previous history. So, already having pre-existing anxiety or depression, or, as mentioned in previous slides, trauma puts new parents at risk of developing a mood and anxiety disorder in this period, as well as history of child abuse that kind of falls in under kind of the trauma, adverse childhood experiences, so really challenging adversities that children may experience kind of in the early developmental phase, put them at risk for experiencing mental health difficulties across the lifespan, just kind of in more general sense in terms of the population, but the transition to parenthood, pregnancy, postpartum, all of the changes, hormonal fluctuations, that all kind of amplifies that risk. The number of children as well. So children can be very demanding, and so as the number of children in the family increase, the mother also is at increased likelihood for developing a postpartum mental illness. Education level as well, so lower education level is associated with increased likelihood of developing a perinatal mental illness, and that's kind of for the reasons that with higher education we tend to see that there may be more income, there's more access to resources, there's less barriers to care, and so not having access to the support that is a really fundamental part of the well-being of childbearing families puts them at a significant risk. Some of the social risk factors for perinatal mental illness include inadequate partner or social support, and so social support is, as previously mentioned, is a really important part of the well-being of new moms, new dads, right? People always talk about it takes a village. Some people will transition to parenthood and they're looking around like, well, where is the village, right? They need that support to kind of step in and provide breaks, give them an opportunity to take care of themselves, to be able to kind of rest, to be able to reestablish, engagement with things that, bring them pleasure and joy, as well as having that connectedness with others is a major buffer for stress. And if you were here for some of the presentations yesterday afternoon, that was something that was emphasized, that social connectedness, social support is a major buffer for stress. And stress is something that is a risk factor for developing a mental health disorder, and one in the perinatal period. Recent loss or grief, that's another factor as well. And so kind of with moving through milestones in life and giving birth is a significant one. Transitioning to being a parent is a significant one. That can stir up grief. Grief can kind of surface during that period of time, right? And so for a mom who's transitioning to parenthood, that may have lost her mom, or is estranged from her mom, right? The grief of not having the presence of that person, that support, maybe the experience that they were expecting can be something that is dredged up during this time and increases the risk of developing perinatal mental illness. as well as kind of barriers to care or discrimination. That is another risk factor as well. And so we can see that maybe more in terms of looking at groups that may be a bit more stigmatized, such as teen parents, adolescent parents, so them not necessarily being heard or validated in the way that a more mature woman who is married and has life in order may not be validated in that same way, right? And so it's kind of important, especially as a healthcare provider, to be aware of kind of biases that you have and the stigmas that exist, and to be able to support those who are, a bit more marginalized within this community. And so for partners, some of the risk factors that increase the likelihood that, perinatal mental illness, anxiety, or depression can occur would it be maternal depression. And so that was one that was previously mentioned, that maternal depression was the greatest predictor for paternal depression. Feeling burdened or trapped, having the additional kind of financial responsibility, maybe there are financial constraints, financial stress, having the societal message that, dad, the man in the relationship, is the provider, that can be a trigger for anxiety in new dads, or dads who are, going through the process of, adding another child to their family. Also kind of being outside of the circle of attention, right? And so during pregnancy, a lot of the attention is on mom and the baby and the growing belly, and dad is kind of on the margins of that. And then but there's still an ability to kind of maintain that connection, at least between mom and dad in the relationship. But then, once baby is born, then attention generally tends to shift onto baby. And people are kind of like, okay, mom, I'm here to see the baby, right? And dad, again, continues to fall in kind of those outer bands of that circle of attention. And so that's difficult as well, and so because then dad doesn't necessarily receive the support that he may need during that time, and is also struggling with feeling disconnected or deprioritized by their partner, who now has to shift their attention to focusing on their recovery, as well as meeting the demands of a newborn. As well as sleep deprivation, that's a significant factor as well, that can exacerbate the risk of perinatal mental illness occurring, and again, kind of missing the more intimate aspects of the relationship, right? That can be something that can be deprioritized once baby is born. Okay, and so if there is, signs or symptoms of a perinatal mental illness, anxiety, depression that is present, some of the factors that can amplify those symptoms would include the sleep deprivation, physical pain, so thinking about kind of moms in those early weeks, right, having to recover physically, as well as dealing with the sleep deprivation, unresolved grief or loss, estrangement from their own parents, or complications that have kind of occurred during the childbearing process. Health conditions in parents or babies, so, situations in where baby, may need additional medical attention, maybe in the NICU. That can be something that can be particularly stressful for parents and families, and can increase the risk of postpartum depression and anxiety. The temperament of the baby, right? Sometimes there is a mismatch between, parents' temperament. Parents may be really laid back and chill and relaxed and kind of expect that baby will be pretty easy in that way too, or they're just going to sleep all the time. But then maybe they get a baby that is more alert and more active than they anticipated, and so that puts an extra kind of demand on parents as well to meet the needs of the baby. And then other age-related stressors as well. So previously mentioned kind of being an adolescent parent, teen parent, and then being an older parent as well. Superwoman syndrome, that's another one, kind of this idea that we have to, as women, do it all and do it all perfectly, right? We've got to be the perfect mom, we've got to have the perfect nursery, the Montessori playroom, we've got to kill it at work, we've got to be the best partner, we've got to snap back, we're going to be in our pre-baby body at 6 weeks. All of those kinds of expectations just further drive anxiety and stress. And so we'll talk about some of the things that are tackled then in psychotherapy. But in terms of the role of healthcare providers, screening, right, by anyone who meets with childbearing families, so OBGYNs, pediatricians, midwives, they have a lot of opportunity to help to assess and identify if there are some signs that are showing of depression or anxiety or some other mental illness in new mom, new dad, pregnant or expectant parents, right? And so it's the PSI, and that's the Postpartum Support International organization, who does a lot of research and advocacy and training. They recommend that moms are screened at first prenatal visit, once in the second trimester, and again in the third trimester, and then pediatricians can kind of help to get involved following kind of childbirth, where we know that those visits with the OBGYN kind of tend to taper off, by trying to screen for depression or anxiety at those well checks in the first year of baby's life. And so there are some highly researched and validated measures that can be used with this population. It's the Edinburgh Postnatal Scale and the Patient Health Questionnaire, and those are readily available online. And I've also included them in a resource list that will be accessible at the end of the presentation. And so in terms of talking about talking about mental illness, talking about mental health, trying to assess, it's really important to ask about things like, are they experiencing any thoughts that are distressing and are scary, how they feel like they're doing, asking directly about thoughts about death or dying, and just kind of making it, opening up that dialogue, making it okay to talk about their own well-being and their own mental well-being, right, during a time where there's so much emphasis on baby and how baby's doing and progressing and developing and all of the needs being met. Checking in with parents and asking directly about their experiences and trying to then connect them with practical sources of support based on what it is that they're expressing that their concerns are, or referring over to a psychotherapist or a psychiatrist or community resources that may be available. And so, as mentioned throughout this presentation a number of times, social support is incredibly important. We've talked about how important it is in the role of mediating stress, buffering that stress, and so it's essential to ensure the mental well-being of childbearing families during the pregnancy and the postpartum period. In terms of mental health treatment, some of the kind of themes or focus points throughout psychotherapy for perinatal mental illness. We tend to surround identity change, so looking at kind of shifts in, who that individual feels as though they kind of have left behind versus who they're becoming, and helping to kind of reestablish and reconnect to themselves in the postpartum period, dealing with grief and loss that might surface throughout childbearing process, checking in expectations versus reality. Are expectations realistic, or is they reasonable, or are they setting that individual up for failure because they're just simply highly unrealistic? And so when that parent can't meet that expectation, then they think that is something that is intrinsically wrong with them, rather than adjusting kind of the way that they're thinking about, thinking about, what it is that they ought to be doing or others should be doing, or how things should be going. As another important aspect as well is reducing comparison. And so with social media, we have access to everyone's highlight reel. That's where we see all those beautiful nurseries, Pinterest too, and those Montessori playrooms, and all those really expensive developmental wooden toys. And just parents can kind of get into the trap of feeling like if they cannot afford, if they cannot provide that means that, they are not doing what they need to do as a parent. And so helping them to kind of focus in on what's kind of within their control and what's within their means is something that we would work on as well. We kind of address superwoman syndrome, so wanting to do it all and do it all perfectly, which we shouldn't really even have a conception of, because that is not something that really exists. Working on communication and conflict resolution. So in terms of communication, helping parents to maybe ask for what it is that they need, being able to express themselves, being able to gain more social support, as well as working on conflicting ideas or thoughts or ideologies that they may have with their partner about how parenting, what their values are in terms of parenting or how things are going, as well as focusing on increased support and referring for other support methods of connection. And so there are a number of evidence-based treatment models for perinatal mental illness. So cognitive behavioral therapy is one, which is shown to be very effective for the prevention and treatment of perinatal depression and anxiety. So that looks at, how individuals are thinking about themselves, about the way their situations, and trying to identify kind of any thoughts that are unhelpful or negative or distorted, as well as finding ways to cope with emotions and doing and engaging in the behaviors and the actions and the activities, the things that work. Interpersonal therapy, there is a perinatal modification to this therapy that's manualized to treat depression, and it's shown to be quite effective along with cognitive behavioral therapy, and this looks at addressing issues within relationships for that parent. Psychoeducational group therapy, so being connected with others who may be in a similar stage or dealing with similar experiences, and having the opportunity to kind of learn more in relation to others. And mother-infant or parent-infant therapy and education. So that's a therapy that focuses on attachment between the parent and the child. And kind of just following along with talking about attachment, so we're talking about the emotional bond between parent and child and that psychological connectedness. And so part of forming a secure attachment is to be able to be a responsive caregiver. And so when baby, signals that there is a need, parent, is able to respond to that need, and that helps the baby to develop a secure attachment and carry that attachment kind of throughout life, and that shapes the way that they see, others, how they interact in relationships, and how they see the world. And so increased attachment security is one of the benefits of managing a perinatal mental illness. Maternal mental illness is one of the main barriers to secure attachment. And so we really do want to look at focusing on, the mother's experience and managing her mental illness, because it also impacts the well-being of her child, right? And so secure attachment sets kind of the pathway for a child to develop emotionally, socially, cognitively, and that kind of starts going into the area of kind of infant mental health, which is another presentation for another health conference. But through managing perinatal mental illness, especially depression, these are some of the things that we can expect to be a result of that, right? So parents are better equipped to manage challenges that come up in parenting, form better relationships with their children, tend to have healthier children, that reduces the likelihood of, those children going on to develop behavioral disorders or mental illness in their lifetime. Parents are less likely to use harsh punishment, and it helps to kind of shift the way that parents experience their children. And so healthy children need healthy parents. That first 5 years, that is critical for brain development. By age 5, the child's brain size is about 90% of the size of an adult. And so there's a lot of work kind of going on in those really cute little heads during that time. And it's really important for us to be able to lay a good groundwork, help those children with kind of developing on track, and reduce the barrier of mental illness in the parent as one that is getting in the way between them and responsive caregiving. And so mental health really starts at conception. It starts in the mom while she's pregnant, her mental well-being, and throughout her journey through labor, delivery, in that postpartum period, that, as I kind of mentioned and touched on briefly, impacts the development of the child, that infant mental health, right? We want to build resilient children who go on to be healthy adults, and as such, it's important for us to kind of go back kind of to the root and make sure that we are supporting a population that is vulnerable, is at risk, and needs that support to, kind of basically build society, right? And so that is pretty much the presentation. Sorry, the last couple slides are a little bit rushed. I know that time is up, and I'm aware of that. Thank you very much. It was my pleasure. And
thank you very much, Dr.